many people are starting to wrap things up for a bit of a break at the end of the calendar year. So again, welcome. I'm Andrea Baer, Senior Technical Advisor with USAID Washington in the Office of Population and Reproductive Health, and here with my colleagues from FHM Engage, Judy Maboya, who you see on screen with me, and Elizabeth Penna, who always helps us run everything from behind the scenes. First of all, just to say that this session is being recorded, as you can probably see, and we will share the recording later on the Health Market Links website. So this is our final Healthy Markets Community Practice session for 2023. And obviously today we're focusing on Ghana, and we are very excited to have a great lineup of speakers, and we can never thank them enough for the willingness to put the time in to prepare and be here. And I just want to share that while, even if we have a slightly lower turnout today, which I doubt in the end we will, that we're finding many people are going back to the recordings and the slide decks later. So again, thanks very much. So I also want to welcome my USAID Ghana colleagues who are probably on the line already. And just as a reminder, so the Healthy Markets Community Practice, we're really focused on markets and the role of private sector markets in the broader total market, and thinking about market development approaches. And the idea here is always to do a rapid sharing. So in the past, sometimes sessions would spend 45 minutes on one particular project, which really does do full diligence, if you will, to that. But this whole year, we've been trying a different format, which frankly, we're getting really good feedback on, and that is much more of this rapid sharing. So we appreciate everyone's receptivity to hearing, in 5 to 7 minutes or 8 minutes. We're always targeting 6 minutes from our speakers. And I will just apologize in advance that I will be a bit of a timekeeper. We'll allow a little bit of extra time at the start for Judy, as she will set the stage with just an overview, really, an introduction to the Ghana family planning market. And the idea there is to just set the stage for the speakers that follow and to generate good dialogue. So I know everyone is very good at being on mute, so thanks for doing that. And please feel free to put your questions in the chat along the way, and you can flag them to the individual speaker, and maybe sometimes those speakers will reply in the chat, and then we'll come back to them as much as possible in a discussion format in the end. So with that, and also, I guess one other thing I want to just give regards on behalf of Ben Light, my UNFPA co-sponsor, who's not able to join us today. And also greetings from Farhan Yousaf, whom you all remember, and he generally co-facilitates with us, and we're hoping he'll be back in the future. So our presentation lineup here, you can see first, we'll hear from Judy, FHM Engage with the market overview, and then just a quick run through. You'll see we have Teresa from SFH, Eric with MSI Ghana, Kwesi DKT, Zilla on behalf of Salient Advisory, Dr. Oluwa with mPharma, Eugenia with Jhpiego, and Salamatu for TFHO. And then hopefully we'll have time for discussion. So with that, over to you, Judy.
Thank you so much, Andrea, for that introduction. I wanted to open up by saying that Frontier Health Markets is a USAID-funded project to strengthen private sector participation primarily in family planning and maternal neonatal child health products and services within mixed health systems. So I will be taking you through the Ghana family planning market description, starting with an overview of the health system in Ghana. Slide, please. Ghana is a lower middle income country with a vibrant private sector. This being despite a recent economic slowdown due in part to the COVID pandemic and rising rates of inflation. However, we have seen commitments from government of Ghana and development partners who are intentionally working with private sector stakeholders to diversify the economic base and increase private sector-led investments. Next slide, please. If we look at financing for family planning commodities, we see that despite the availability of donated family planning products in the market, and national health insurance, which covers family planning, end users will still pay both in the public sector and private sector to access family planning products and services. So at this time, the government of Ghana is committed to contributing to 10% of the cost of procurement of family planning commodities by 2026, and to increase that contribution to 20% by 2030. The primary funders of commodities in the country are USAID, UNFPA, and the West Africa Health Organization. Just under 70% of Ghanaians have health insurance, which ranges across the country. The national health insurance has included recently, this is in 2022, included family planning in its benefits package and will reimburse service provision for injectables, implants, and IUDs. NHIS does not reimburse the cost of FP commodities. In the public sector, the commodities are accessed free of cost. However, there may be a small service fee charged for clients. And in the private sector, private health facilities with service level agreements in place with government can ask for free commodities through the Ghana Health Service. They will charge a service fee to clients. You will also find FP commodities available in private health facilities, pharmacies, and over-the-counter medical suppliers as well. Next slide, please. If we take a look at FP service delivery, family planning products and services are available across a wide range of service delivery points in Ghana. Task shifting has allowed for injectables and implants to be provided by auxiliary or enrolled nurses, while IUDs are provided by nurse midwives. There is, however, inequitable distribution of trained human resources for health, and the number of trained providers remain a challenge in expanding access to methods and lacks in particular. So we can see, across the methods, you have provision at health posts, at hospitals. You do have, however, a limitation in terms of pharmacies and other retail outlets that only the short-term methods will be available. Next slide, please. It is estimated that the family planning market size, the potential, the number of women with reproductive age in need of contraception is 4.5 million women. From that market, about 2.2 million women are currently using a modern method, 1.7 million of whom are in the public and SMO sectors. However, it's estimated that the market is failing 2.3 million women. The unmet need is highest among younger women, 15 to 24 years, who are unmarried and sexually active. The use of traditional methods is also highest amongst unmarried, sexually active women and has increased when you look at, when you compare the most recent demographic health survey, up to 17% from 12% in 2014. Bono East, Volta, Eastern, and Greater Accra are the regions with the highest unmet need. Next slide, please. While MCPR is increasing in Ghana amongst all women of reproductive age, it is increasing faster amongst unmarried, sexually active women. So we've seen substantive growth, up from 31% in 2014 to 46% in 2022. It's also interesting to note that the use of traditional methods is also increasing amongst unmarried women, unmarried sexually active women, compared to the 2014 demographic health survey. Next slide, please. MCPR varies across regions in Ghana. The highest rates in Ahafo, Western, Central, and lowest rates in Northeastern region. And surprisingly, the regions with lower MCPR also have higher rates of teenage pregnancy. You can see that reflected in the Savannah region. Next slide, please. The method mix among married and unmarried women is different, with emergency contraceptives accounting for 25% of the modern method mix amongst unmarried women, followed by implants and injectables, and condoms. Injectables, implants, and oral contraceptives account for 70% of the modern method mix amongst married women. Next slide, please. Based on an analysis of the 2022 contraceptive volumes, private sector is the main source of oral contraceptives, condoms, and emergency contraceptives. It does, however, also have a role in the delivery of injectables, implants, and IUDs. We can see that private sector contributes to 87% of all oral contraceptives distributed, 97% of the condoms, and 100% of emergency contraceptives. So there is no emergency contraceptive available through the public sector. Next slide, please. If we look at the methods distributed through social marketing, 87% of all oral contraceptives and 13% of all contraceptive injectables are delivered through the private sector. TFHO is the major supplier for both methods in the private sector. Emergency contraceptives are not available in the public sector. DKT is the major source. And implants are primarily distributed through DKT and MSI. Next slide, please. That will be my last slide. I'll hand it over to back to Andrea to welcome Teresa.
Judy, thank you so much. And as I imagine the group can anticipate, there were several more slides in this market description that you could have shared. And I just want to reiterate that there will be a full-length market description available and shared by the FHM Engage project coming soon. And I think that what you did share sets us up perfectly for the presentations which follow, really hearing from a number of SMO partners and other actors taking innovative approaches to increase access to family planning. And I also anticipate that there might have been some points in those slides that prompted opportunity for discussion, maybe differing views, and so on. So happy to come back to those later. And next up, I'd like to welcome Teresa, the country manager for Society for Family Health International. Over to you, Teresa.
Thank you very much, Andrea. I hope everybody can hear me.
We can hear you.
Thank you. I must say that introduction by Judy makes this presentation very apt to follow with. And at Society for Family Health, we being a Pan-African organization, we've impacted the lives of women in the sub-region with our presence in Ghana, Nigeria, Sierra Leone, and Liberia. And over the next few minutes, I'm going to try and keep to the time, Andrea. We are going to look at improving the access to family planning service delivery through community pharmacists and over-the-counter medicine sellers. So join me as we go through that. Next slide, please. So by way of background, just as Judy projected, out of the 16 regions of Ghana, we were targeting 8 for a pilot that was funded by, as shown, UNFPA Ghana and the West African Health Organization. And this project took place over 6 months just for the training and orientation of the CPs, that's the community pharmacists and over-the-counter medicine sellers. And as she rightly said, the choice of the regions really was because of the unmet need as shown and the high teenage pregnancy. Despite most of these women having, knowledge or having one way of acceptance of a family planning method, yet these numbers were quite low. So what we did, choosing these 8 regions, that is Northern, Bono, and as you can tell, a greater part of these regions, 6 of them out of the 8 are in the southern sector. But again, most of the numbers as projected by Judy are quite in the northern region. So there still needs a lot of work to be done in the upper east, upper west regions, the Savannah region, to be able to capture these service providers. And just by way of background, the pharma industry in Ghana is quite similar to what pertains in the sub-region. And by way of numbers, as we can see, just about 4,500 community pharmacists are present, whole country, and then 20,000 plus over-the-counter medicine sellers. However, based on the interest of the service providers, because what we did, we didn't just blank train all the pharmacists or over-the-counter medicine sellers present in these regions. It was out of those who had the interest, and also because by way of policy, only just a few pharmacists have been trained to be pharmacist vaccinators or to give injections. We had to select these pharmacists, partnering with the Pharmaceutical Society of Ghana Association and also the Community Pharmacy Practice Association. So that is how the methodology we used to select the regions and the target service providers that we trained. Next slide, please. So the approach was we were going to strengthen the quality of service. As rightly said by Judy, most of the commodities provided by the private sector through the pharmacies and OTCMS is the short methods, that is by way of oral pills, the condoms, and then the ECs, the emergency contraception. So we had to build the capacity of these service providers, going through the method mix, and especially putting a key highlight on FP counseling, because we all agree that the pharmacies and the medicine sellers or the drug shops are the first point of call for most of these women in the community. So once you capture them, these clients are able to be counseled appropriately, and also, if appropriate, sort of refer them to the channels to get the longer acting methods on the national health insurance, as said. Again, by the introduction Judy made, we were made to understand that unmet need is quite high in the adolescent, and the ability for these service providers to provide youth-friendly services in the community was key in the training. And again, data. Trying to capture data from the private market is something that has been challenged across the sub-region. So data management, using tools or resources that the public sector uses to actually document or capture data of the number of women that are seen or the methods that are given out were also highlighted on. And again, because this is an area that has always been in the public sector, we had to make sure that there was, demonstration and written demonstration. This was also used as a way of introducing the Sayana Press, the DMPASC, and, as a national conversation through the Family Health Division, scaling up the uptake of this is quite key in the national agenda. So this was also highlighted during the training. The commodity supply, again, in the private sector needs to be improved, especially with the long-acting commodities. So we, again, improving the supply of the commodities were also key. And most importantly, for services that, especially the medical sellers or the drug shops, that they could not provide by way of their training, we needed to find a way to link them to the nearest, public or private health institution that provided these services. So that was the approach that was used in the training. Next slide, please.
Yeah, so, Teresa, I'm so sorry to interrupt, but if you can just wrap up in a minute. Thank you.
Okay, that's fine. The expected outcome as we go through the period, we've just had this for 6 months, just training. With additional funding, we can actually come up with looking at all these commodities, getting data, capturing, and then looking at these specific regions to be able to upscale to the other regions. Next slide, please. By way of recommendation, what we found out is that, looking at the numbers, even for those of interest of the community pharmacists, just a little over a 2% target was achieved for the training and orientation. Again, we want to use this as an opportunity to scale up, as mentioned. And again, these trained CPs and OTMSs could present an opportunity to upskill the DMPSC, as said. For policy, we need to engage the stakeholders or policy or regulators, such as the Pharmacy Council of Ghana and then the Pharmaceutical Society, so that beyond this, they will be able to actually own this and monitor accordingly, strengthen the capacity as we go on, and also incorporate this into the CPD training, sort of a hybrid model, so that pharmacists, as we go through the training or as we go through the curriculum, will be able to imbibe this family planning service delivery. And next slide, please. I think, yes, that is it. Thank you. And thank you for the opportunity. You can reach us through these channels. Over. Thank you.
Yeah, Teresa, thank you so much. Everyone, please put any questions for Teresa in the chat. And there were a few things that caught my eye for sure. Definitely the youth-friendly services and capturing private sector data that you noted. Can we go to the next slide? And I would like to introduce Eric, the lead program manager for MSI Ghana. Over to you, Eric, and welcome.
Thank you. Great. So next slide, if we could go. Great. So I'm presenting for MSI Ghana's private sector engagement approach. That's how we deal with private sector providers. Next, please. Great. So it's been largely mentioned today over the two presenters that we have a very large market for SRH and FE in Ghana. And then why we engage the private sector is because there's an analysis by the World Bank which tells us that about 50% of healthcare services are sourced from the private sector. Additionally, we also have a lot more women, over 35% contraceptives being accessed also through the same private sector. Then we also see a very high market within the younger users between 15 to 19, ranging 61% also picking up services from the private sector. So what it means is that there's still markets for us all to tap into. So this is how our franchise model works. So MSI Ghana clusters private providers into a network called the Blue Star Network. It's only a cluster of private providers that come together to share the same vision of MSI to advance SRH and FP in Ghana. So what we do with them is that we conduct clinical trainings, we conduct quality assessment trainings, we also do refresher trainings once every year. We give them commodities. If I say commodities, what I mean is the FP commodities. I mean, literally for free. We give them equipment to also start with the IUD insertion kits, implant insertion kits. We do demand generations for them to also ensure that there's demand created for them. And then also we do community sensitization with community volunteers in the areas where they operate. So next slide, please. So, I mean, what is this approach about and how do we do this? So we do this through the market systems development. I mean, we look at key market constraints, what lack in the private sector, what opportunities exist, and then how we can also advance a value to the private sector providers. Because the government largely looks after the public facilities, but the private sector providers usually are left hanging. So MSI developed strategic drivers, which if you look on the slide, the diagram on your right, they're highlighted in the blue. I mean, quality, information, community security, as is mentioned, and then also regulation. That's also one part that it's a bit cumbersome to navigate. So we're playing an aggregator role to be able to look at them from the top, and then how we can support them to go through all of these to advance FE and SRH in Ghana. So next slide. So of course, this is our strategy. We still know that we have a lot of markets under 25 years who we can advance SRH to. This about 56%, and we've heard, I mean, from previous presenters that there's still high unmet needs. I mean, in this case, exactly from 32% from the 19-year-olds, and then also there are a lot of myths, misconceptions, and then norms within the access to FP in Ghana. Now, we've rolled out, I mean, MSI Ghana led the rollout of FP on NHIs in last year. It was very successful. I mean, waiting for the LI to be completed for us to have a national rollout. So what this means is that advancing UHC also, remember that this year, I think there's a conference in Ghana on UHC, and the government recognizes the role that private sector providers can play in advancing UHC. Then also we heard that NHIs is also, I mean, a very big engine that will be used or can be used also to advance universal health coverage. So what this means is that we've identified the government as a very big partner in advancing FP in Ghana. Since this is their common, this is very core to what government wants to do. So once this pilot has been undertaken, the next steps will be to have a national rollout for clients to have less barriers, I mean, less financial barriers to FP in Ghana. Then also we look at providers who also want to have a very successful business. I mean, how they will get representation from government, how they'll get assistance to navigate through the regulatory environment, and how they can get providers and get some points to renew their PINs, and then the nurses and the midwives also to have training opportunities to get some form of certification for their PINs. Then also clients who are the center of all that we do also need to have quality services, and they are also a very big focus in our work. So all that we do with the providers and then government is geared towards the clients having a safe and an easy service. Could we have next slide? So of course we identified some market constraints in for SRH in Ghana. Number one, as it largely mentioned, community security. I mean, ensuring that all private providers have access to commodities easily and on hand. Because we found out that there are lots more times that there are shortages in Ghana, and then they can't get commodities. Then also, it's mentioned also on the earlier presenter that getting information into the government database, DIMS, also becomes a challenge, because public sectors do, but the private sector largely don't report into DIMS, which is the government database for information, which also can be used for forecasting if it comes to these commodities, so that, I mean, we could also request for more. Then the other part is also limited enforcement of regulations of quality standards. Of course, we know the Health Facilities Regulatory Agency does licensing of facilities, but after the first set of inspection and license is awarded, they come back also the next 2 years, or when the set expires after 3 years if it's a long-term license. So that's one of the challenges there. I mean, what would the MSI also do in this new engagement strategy to ensure that for the facilities that we work with, quality is assured and then regulations are being followed? I mean, fourth constraint we identified is information. There are lots of myths, I mean, around IUDs, around implants, misconceptions on how it reacts in the body and how people even conceive it. I mean, that's also another constraint that we identified. Then the last one is how the private sector providers can attract qualified providers, as in doctors and then midwives, especially to advance IUDs in their facilities in Ghana. So next slide, please.
Yeah, and Eric, sorry to interrupt, but if you can wrap it up in a minute or less,
yeah, this is the last slide. Yeah.
Thank you.
So how can these be addressed? I mean, so we serve on community security consortium to ensure that we can advance some more advocacy on government to increase or improve upon the resource envelopes. I mean, then the next one is also to ensure that all credentialed facilities have access to DIMS where they can report FP data into for government to use also for forecasting. Then the third for us as MSI is to also use Safe Care accreditation, which is internationally accredited quality improvement platform, to ensure that facilities that we work with follow through the improvement process if it comes to quality. Fourth one, of course, we identify information and the misinformation, and then the approach is to use community-based mobilizers, the health promotion officers, district health management teams to be able to advance and then disseminate the benefits of family planning. Then finally is to work with the Private Health Facilities Association of Ghana and then other private sector alliances to advance advocacy to government to also post qualified providers into the private sector facilities. So next slide. Yes, thank you, and all feedback are welcome.
Wonderful. Eric, thank you so much. And I just want to note as we queue up the next slide that I was certainly struck by how much MSI's approach is in sync with what we're thinking from a market development approach and having the client at the middle. So with that, over to you, Kwesi Yasin, welcome, Regional Director for Anglophone West Africa with DKT. Kwesi, welcome.
Hi, thank you, Liz. Good afternoon, everyone. Can we move to the next slide, please? Next slide, sorry. Okay, so just a quick introduction of who we are. We are an NGO, but we operate like a business. So we are cost recovery, and we use our skills from the business world to, by business, I mean profit-making world, to leverage the distribution in the private sector. And we develop our own brands and sell them just like we would, but just to recover the cost of the commodities or products that we bring into the country. Next slide, please. DKT, I think this is not, but DKT Hour is made up of Ghana, Liberia, and Sierra Leone. And so we have a lot of people in Ghana who support the operations in Liberia and Sierra Leone. And so most of the support is from Ghana. We don't have a full house in the other two countries, but we managed to get things done in those countries as well. Next slide, please. So I'm going to be talking briefly about what our approaches have been in the private sector. Next slide, please. Okay, so private sector approach. So this is what we do at DKT. Per this slide, you'd see our distribution process, and then you would also see some of the initiatives we have with the private sector. So we have partnerships with the mostly the pharmacies and the drugstores or medical stores, medical outlets, chemical stores. But we also have another activity we do with some hospitals, which we sell or promote the long-term methods through. So we have something we call the Lydia Partner outlets, and that is made up of pharmacies, which are the Lydia Partner pharmacies, and we have the Lydia Partner clinics. And so we build their capacity, and they would then in turn offer services to the people who want to take services from the private sector. In terms of trade, we have two approaches, and what I've shown here is our approach from our salespeople to trade and then eventually to consumers. So what we do is make sure the products are available in the outlets, private sector, of course, and then there's some activity we do to make consumers and aware of where they can access products. And so we do some demand generation activities. If you look on the slide, you see on the map where we are covering, this is what we do directly. And on that map, you would find the red dots, the big red dots are the media partner outlets and where they are situated. And then it also tells of the number of outlets we cover directly. So between 2020 and 2023, that's how much we've grown. We've grown from selling to 2,487 outlets to 4,000. These are the ones we cover directly. We have a second distribution plan, which is where we work with distributors and wholesalers to make sure that retail outlets also have the products. But what we do, we consistently do our demand generation activities to make sure that everybody has access to the information they require to be able to go look for products in the outlets. Next slide, please. So these are some of the pictures. So one of them is what we do, the activations at the beach. One of our staff educating women on the female condoms. One activity with Market Storm with some of the guys who bought some and got some free samples. And the third one on the left being the when we introduced the HIV self-test kits. And DK2 was the first to introduce it in Ghana before it was picked up by other partners. So we have engagements in partnership with the clinics in the local communities that we do them, and then we do some health screening, and through the health screening, we introduce them to knowing their statuses. Next slide, please. Some of the new products we introduced over the period, the oral quick, which is the HIV self-test kit, which is not which we don't use blood for, but saliva or the fluids from our mouth, and then some variants of our condoms, and then we also introduced the single pill emergency contraceptive onto the market. If you check the ratings, which is on the right side, we asked people why they use our products, and we just wanted to be sure what it is that made them want to use our product. Some said it's well known. Most of them said it's well known, actually, 40% of them. And then some said because it does the job. Some said it's affordable as well. And so those are the basis for which people would use our products. Next slide, please. Okay, so I think we skipped one slide. Yeah, that's it. Okay, next slide. So our partnership with the private sector collaborations and market access. So as I mentioned in the earlier slides, we have some collaborations with the facilities. Since we are not clinical, we just make sure that we launch the products, our brands, and then we make them available. So for people who would need the clinical side of things, if they are not using MSI and they are using us, then it means they would have to go to our partners because we can't offer the services that MSI does. And so we would rather continue to do the the capacity building of the people who render these services in the private sector. So these partnerships is to expand our access, the access to our products to the consumers. We also do a bit of the products that we offer is to ensure that everybody has what it is that they need as far as FP is concerned. And so some things that would normally not be on the public sector front would be the lubricants that we have in trade. So we launched them because it's one of the things that goes to ensure everybody has what it is that they want in a product. Then we have a collaboration with government. So government does a bit all the that we do because we as I said, we don't have the technical expertise for that, and so we collaborate and partner with them to build the capacity of the service providers. One of the things we recently have done is a partnership with the Ghana Health Service and the College of Pharmacists. We are trying to open up the pharmacy space to be a place where women can go to for injectables. And so it's a study we've just ended. Very soon we should be sharing we should be disseminating that the details of that study. And so hopefully we are able to get to open up the pharmacy channel as an avenue for people to get injections. There are people, as Teresa mentioned, there are people who, pharmacists or community pharmacists who have already been trained on that front. And so if it became formal, then it would be another channel for women to be able to access injectables. Next slide, please. I'm just about to round it up. Okay, so this is just a picture of some of the things that we do. And this is all in collaboration with the Ministry of Health. And over the year, which is the year 2023, these are the trainings that we've conducted, training sessions that we've conducted in collaboration with the Ministry of Health, who provide us with the technical expertise. Right? And so we can see the next slide, please. Innovations impacting access and affordability. So we had to introduce medical abortion compacts. This was a thing we did with the MSI some time back. And so to make sure that every woman has, what do you call it, access to safe abortions, and we decided to introduce that. And the plan was to reduce maternal mortality rates. We also introduced the HIV self-test kits because we thought that everybody needs to know their statuses. And it's one of the kits that, it's the only kit actually that prevents other people from knowing one's status. But we don't just put the products there, we train the administrators of the product on how to counsel people before they can use the product and what the next steps should be. So we don't just put products in the outlets. And the last item being the affordable SHRH products that we introduced. For instance, we introduced 2 brands of condoms. One of them is the low-priced one, which is meant for the masses, and that's the KISS condom. And then we have also the Fiesta condom, which is the premium. And even the premium is quite affordable as well. So just to ensure that everybody can have access to a product or a service of choice, right? Next slide, I think that should be it. Okay, so our future collaboration. So we're hoping that the training initiatives, so we would like to collaborate with the private sector on how to build capacity of service providers, because the thing is, a lot of people, we have some LPCs or some facilities where trained personnel move on quickly. And so on a regular, we should be training people, building their capacity so consumers are able to get the services they require from the right sources. Collective advocacy for supportive policies. And one of them is the just ended DMPA or injectable study that we carried out. How do we get the woman close to what it is that they need? And so opening up channels would be quite a helpful activity. And once we finish this, the next step would be to advocate for it to become a policy. How are we going to do that? And we would want to collaborate with the right environment or the right institutions to get this done. And the last one being ensuring that products are available the best way. We just had a conversation with some agencies that could help in this technology space where people can have access to products at all times. So we are looking at a lot of collaborative effort in the coming years to see how we can use data platforms and then telemedicine activities to make sure that women and everybody looking for products, including men, would have access to them. Next slide, please. So this is just 4 pictures that show some of the activities that we do and where we go. So it's really just a picture to show some of the things we do. So thank you. I think that's the last slide. Thank you.
Awesome. Thank you, Kwesi. And there's a lot there to unpack for sure. But one of your final remarks was, I think, a perfect cue up to our next speaker, whom I want to introduce right away. We're lucky to have Zilla from Salient Advisory, and I think she's going to talk about a digitized supply chain solution project, amongst other things. So welcome, and over to you.
Thanks, Adre. Hi, everyone. I'm Zilla Waminaji, a consultant at Salient Advisory. And today I'll be sharing some of our findings and recommendations from a case study that we conducted to explore how African health supply chain innovators are facilitating access to contraceptive care products and services. But first, I'll start with a quick overview of our company. Next slide, please. At Salient, we're a health consulting firm that advises global health stakeholders on innovations in African health tech ecosystems. Our team is distributed across Nigeria, Kenya, South Africa, Morocco, and Canada. And one of the major things we aim to do is to highlight new models that are being created to deliver health services across the continent, and also connect global change makers and innovators to opportunities that can advance public health outcomes and also promote equity. And one of the ways that we do this is by producing market intelligence work that informs key stakeholders and also their decision-making processes. Next slide, please. And this case study is a recent example of the market intelligence work that we do. To provide some background and context, this case study was part of a broader research on the Pan-African landscape of tech-enabled health supply chain innovators operating on the continent. And in this broader research, we identified 348 innovators who are digitizing health supply chains. And so we saw that there was an opportunity to analyze these innovators and study how they are enabling access to contraceptive products and services. And our approach was to review these 348 health supply chain innovators that we have in our database, and then identify the supply chain innovators who are facilitating access to at least one contraceptive product or who are offering referrals to contraceptive care clinics. And based on this criteria, we are able to identify 116 innovators. Next slide, please. And when we look at these 116 innovators, we see that majority of the companies are headquartered in Africa. And then we have 55% headquartered in Nigeria and Kenya. And these 2 countries, they stand out as the 2 key markets. We also see 37% of the innovators spread across 12 other African countries. And in Ghana, to be specific for Ghana, we identified about 11 companies. Also, we also see some inequalities when we dig deep into this demographic data. We see that only 8% are headquartered in Francophone geographies. And in terms of the women-founded companies, we see that only 13% of these companies were founded by women. And these companies are often based in Nigeria, Kenya, South Africa, Egypt, and Senegal. And so the key takeaway from this is that there are obviously gaps, even in the number of women-founded companies. And it just highlights that there's need for more work to be done in building more equitable ecosystems. Next slide, please. Also, we see these innovators operating through 2 primary models, so the direct-to-consumer models and the direct-to-provider models. On the left, in the direct-to-consumer category, we identified 89 innovators who enable consumers to be able to purchase contraceptives through digital channels. And even within this group of direct-to-consumer innovators, we see them operating in two different ways. And so I will start with the product-focused innovators. We have the online pharmacies who allow consumers to purchase health products, including prescription and over-the-counter contraceptives. And we also have the e-commerce operators who distribute a broad range of non-health and health products, and which also includes contraceptives, but these are often over-the-counter contraceptives. And then when we look at the counseling focus, still under the direct-to-consumer model, we have the telemedicine operators that enable virtual consultations, including contraception-related care, and they also offer product delivery. And then also we have the sexual health counseling service innovators, and these innovators are solely focused on providing online sexual and reproductive health services. And all of these innovators in this counseling focus group, they provide consumers with access to both prescription and over-the-counter contraceptives. And then on the right, we have the direct-to-provider category, and we identified 27 innovators in this pool. And these innovators, they enable providers like the pharmacies and the health facilities to purchase health commodities, including contraceptives. And the two key models that we see here are the order and inventory management solutions. These innovators, they offer digital marketplace solutions to these healthcare providers. And then to a lesser degree, we also have the medical drone delivery operators who facilitate last mile delivery to health facilities. Also to add, across these two models, we also see that 7% of the innovators are operating in both the direct-to-consumer and direct-to-provider category. And an example of an innovator was Kasha that we saw, who offers online pharmacy services to consumers and also offers digital marketplace services to providers. Next slide, please.
And Zilla, just to ask if you can take just about another minute, that would be great. Thank you.
All right. And so to provide an overview of the type of contraceptive products that these innovators offer, we are able to collect product mix data for about 68 companies. And these are just innovators who are distributing contraceptives directly to consumers. And not surprisingly, we have the male condoms just at the top of the chart. But aside from that, we also see that emergency and oral contraceptive pills are also the most common contraceptive products. And these innovators that are offering access to these are mostly online pharmacies. Also in the middle of the chart, we see that DMPA-SC access is also limited. And the common feedback from the innovators was that there was low supply of DMPA-SC from the distributors, and they were also experiencing frequent stockouts. And so these are some of the barriers that limit the availability of the product on their platforms. Next slide, please. And when we focus specifically on the e-commerce companies, we see that they may offer a sizable opportunity to expand access to over-the-counter products. We're able to review the products that were carried by 8 e-commerce companies who are operating in 27 countries across the continent. And we see that Conga Health had the most diverse product mix among the e-commerce companies and was also the only one offering DMPA-SC. In the other two rows, Desert Cat and Glovo, they offer both male condoms and contraceptive pills. And then we see the remaining only offering condoms across, and they operate across 11 countries. And so we see that there are opportunities here to expand the range of over-the-counter contraceptives that are offered by e-commerce companies. Next slide. I think this is the last, that should be the last one. Yes. And just to reiterate on some of the key takeaways. So there are obviously gaps across Francophone Africa and also in terms of the women-founded companies. We've also seen that the product mix for the direct-to-consumer innovators are limited, and so there are opportunities to expand their product mix. And also with e-commerce companies, an opportunity here will be to better understand what the barriers are for them selling over-the-counter contraceptives and how these channels can also be leveraged. And I've also only shared just details about like some of the top 3 key findings from our research, but we still have more findings captured in our report. I'll also post the link to the full report in the chat, and we'd love for you to read up on the report and just learn more about the work. Thank you.
Okay. Yeah, thank you very much, Zilla. And it looks like there's a lot there, and would be interested to dig in more in the future, specifically to Ghana. With that, I'm already conscious of us not having enough time. So over to mPharma next, and really happy to welcome Dr. Hafiz. Over to you.
Thank you. So I'm going to try to be very fast. I think I've overestimated how much time I have. So I might not really be paying following the slides. So I'll just talk about our solutions and how it relates to family planning. So yes, mPharma is present in 6 different African countries, but we have our health services provided in 4. And today we'll be focusing on Ghana. So I'll broadly divide our health services trying to achieve having a primary care service all in one shop, all in one stop. So mPharma wants to solve the problem of accessibility through our franchising model and vendor managed inventory. So it means that pharmacies don't always have to have cash to buy drugs. With our vendor managed inventory, we can supply them the drugs they need and they can pay us back when they dispense those drugs. And we're also trying to see how we can turn all community health pharmacies into primary care providers. We have a solution called Multi-Doctor that is providing in-house in-pharmacy health services. I'll talk about that a bit later. And then we are also concerned with how people can afford healthcare. And we have a range of solutions, which I'll also talk about. Next slide, please. So our patient-facing solution is Muti. Muti can be seen as the answer to how do we want patients to afford medication. So we provide a barrier of, we provide a range of different products under Muti. Firstly, for general medications, patient gets discount and cashback rewards. But what we've seen pharma companies leverage on is our interest-free phase payment plans, which means that for very expensive medications or for very expensive implants like we have in family planning, the patient does not have to pay everything upfront. They can pay some part of it and then spread the payment over a couple of months till they get their implant on. So this is still, we've launched this for oncology, but we're yet to have a partner that has taken advantage of our pay now, heal now, pay later to actually provide some family planning to people. We also have what is called Muti Plus. Under Muti Plus, we allow patients pay a low flat prepayment and then get access to family care. In the next iteration of the service, we will be including some family planning services, such as oral contraceptive pills, like condoms, so that with this prepayment, when people need these things, they would get limited amounts every month with their payment. So it's not just used when they fall ill. They can have access to these things with that single prepayment. And under our Muti, we also do community health. This is where we have nurses go around a walking radius of all our pharmacies to provide preventive health care to people living within the community. They measure their blood pressure, they test their blood sugar, they measure their weight. We also want to iterate this product to be able to serve some family planning needs. So in case when the community health workers are on the field and they meet women who are in need of family planning procedures, with training, they can be able to offer it. And then our in-pharmacy health service. Next slide. So it's called Multi-Doctor. This is our bid to convert community pharmacies into primary care providers. So you can come in and you can talk to a doctor virtually. You can do some point of care testing. Right now, we also offer test and treat for hepatitis, for example. If you do your hepatitis test and it's negative, you can get a vaccination. We also offer counseling and HIV RDTs. And we also want to go further to be able to offer preventive pills for HIV, as well as being able to open up so that patients can pick up their HIV medicines from the community pharmacies. Our virtual care is different because it's not just a video call. It is a video call where the doctor can also examine the patient remotely using our Title Care device in partnership with a Israeli company called Title Care. We're able to provide the solution where the doctor can listen to the chest, look into the mouth, and have a more intimate examination with their patient rather than just a video call. This is also a bit to reduce self-medication. We know people always show up at the pharmacy first to treat whatever ailment is wrong with them. So we've leveraged this, that when you show up without a prescription, you can actually talk to a doctor and get one, and also make sure that you are treating the right thing. Also, our in-pharmacy health service has been leveraged by other NGOs that are into sexual reproductive health to provide family planning services to women who come through the pharmacy. They've been trained on doing injectables and the counseling for orals. And this is currently present in Nigeria, but we hope to be able to scale to Ghana soon and Uganda to be able to provide family planning services in pharmacy. Next slide. Okay, I think we can skip the video. All right, so I'll just round up. So our summary is we are leveraging community pharmacies, equipping them with what they need to be able to provide all types of primary care, including family planning. So what I have presented is a canvas, and I hope our partners here can see the opportunities that they can use to paint on it. And okay. I would answer the questions at another time, but for us, we are very keen on seeing every community pharmacy be the best primary care provider they can be by leveraging all the services that I have talked about briefly. There was so much to talk about, but I decided to just give a very brief overview. Thank you.
Dr. Hafiz, thank you so much. Absolutely fascinating. The idea of basically recognizing how people use pharmacies and converting them to primary care provision, including family planning. So a lot to talk about there, and what's coming more to Ghana. So with that, over right away to Eugenia from Jhpiego.
Thank you very much, and good evening, good afternoon to everyone. Jhpiego is excited to present on this platform today. And in a form of introduction, I like to say that Jhpiego is one of the global leaders when it comes to creating and delivering transformative health services. And in Ghana, I would like to be precise that most of our projects when it comes to FP has been around the public sector. And therefore, partnering with PFSI and Total Family Health has brought to light the catalyzation change where private healthcare champions join the force of enhancing and making sure that LAC services go on. Can we move to the next slide, please? So, with the main goal of this project, I would like to say again that this project is fully sponsored and funded by USAID. And therefore, the main goal was to make sure that the capacity of healthcare providers in the private sector, it's being expanded, and also for us to also know what they have on board when it comes to giving up services like LAC to the general public in Ghana. So there were three main strategies that were looked upon with as objective, where we looked at the expansion of the services and making sure that voluntary LAC services are being provided by these private providers, and also looking at the strengthening of capacity for these healthcare providers in the sector. And lastly, to also make sure that there is a sustainability bit when it comes to IED supplies and implant supplies. Can we move to the next slide? So as I said earlier, still acknowledging our partners, PSI and Total Family Health in this interesting project. We are from Jhpiego had some key roles and some supporting roles that we had to bring on board. So one of the key roles was that Jhpiego led the hybrid orientation of the LAC curriculum that was being kept on the nursing and midwifery platform, where this platform, it's called the World Continuing Education Alliance. So there was some great partnership bringing in the government, that is the NMC, to be also part of this sector relationship. We also had some support that was given to our partners when it comes to supportive supervision, when it comes to mentor-mentee, and also when it comes to, we realized that data is an issue, and some of our presenters earlier have highlighted on that. And therefore, during the baseline assessment of this project, we realized that some facilities had some challenge when it comes to even the equipment, that is the desktop or even a laptop, to be able to pick some quality data to be presented on the DEMS. And therefore, Jhpiego also supported with that activity and also looked at collaborating with our partners when it comes to the research bit of the project. Can we move to the next slide, please? So at the beginning of the project, what exactly made all of us to rally against the fact that we want to venture, and even Jhpiego so interested also to be part of this great innovation? We realized that, as I said earlier, most of these FP services, public sector in Ghana, are so blessed to be able to have more access to it, more training capacity are being built for these people at the public sector. But when it comes to the private sector, there were some bottlenecks and some barriers. And these were the lack of trained personnel, especially when it comes to LAC services in this area, and where there were also biases when it comes to provision of services. And we also realized that there were some supply chain bottleneck, and there were some challenges with even getting instruments in this sector to be able to provide the necessary services that is being required of them. Can we move to the next slide? All right. So with this project, there were a lot of approaches that were being used, some adaptation from PSI, Total Family Health. We were able to have some key strategies and approaches which were being used. The first we looked at was the private sector engagement, and there were some criteria that will make a private sector qualified to be part of this project. And some key things that were being I would like to say it's something that is now a hallmark or something of the project, where we looked at the person-centered care and counseling for choice. There have been a lot of strategies when it comes for counseling in Ghana. We have the RADAR, we have the GATHER, we have the balanced counseling. But this counseling strategy stood out so tall that as we speak now, Ghana Health Service has also been so interested in this approach, and our private providers are first in a kind to get this training done in Ghana with the support of Total Family Health, PSI, and Jhpiego. We also have the self-paced online learning, which I spoke about. That is the hybrid learning, where all the curriculum were being kept on the nursing and midwifery platform, that is the WAKIA, where these providers in their own self-paced go in to learn and make sure they can get themselves well acquainted with some of the knowledge that was there. We also had some approaches that like the mentor-mentee. We also had some great demand generation, which was being carried on by Total Family Health, and some data quality and management too was also a focus. Can we move to the next slide, please?
And Eugenia, I'm sorry, but if you can just wrap up in less than a minute, because I
All
also
right.
want to allow time for TFHO. I'm sorry.
Thank you very much. So with the key accomplishments, as I said earlier, we've been able to partner and build some capacity for our private providers. We've been also able to orient them on the digital platforms. We've also been able to supply them with some instruments to provide lab services in their various facilities. And also demand creation was also part of this key accomplishments, and therefore there were some also data improvements and data quality where 50 desktops were being donated to some of these facilities to facilitate effective data collection. So I think that the next slide will be my last slide. Well, it looks like some of the issues when it comes to private provider capacity development. I'll just talk about two and just run it up, where we saw some attrition of trained providers because these are private owned, and most of these healthcare workers sometimes will be at the private sector to just while away time to get some final posting to the public sector. And this therefore brings some attrition in their staff. And also there were some lack of commitment when it comes to some private providers, some management. Sometimes getting their time is even very difficult. And we know that looking at the great partnership, all these things probably will be kept as projects comes in. And looking at the sustainability bit, we still look forward that private providers still partner with local organizations to get their commodities and Ghana Health Service to get and sustain, and enough commodities to work with. So I will end it here and stand in for questions for Total Family Health also coming. Thank you and over.
Wonderful. Thank you, Eugenia. And moving right on to Salma 2 from TFHO. And I know that sometimes we don't have perfect coordination, and there are projects that relate very closely. So Salma 2, I just want to offer up that perhaps if you don't want to go through all of your slides as is, but maybe just highlight what's unique and complementary, and then we can allow for more time. And also, if you want to make some more generalized comments about TFHO, I think that would be instructive for the audience. Welcome, and over to you.
Thank you for the opportunity. I believe Eugenia has already gone through. I think we did this work together. So probably I think she's mentioned all that I have to present. Next slide. I would just want to talk more about the blended approach and how it was received by the providers. We all know that the private sector is profit-oriented, and it's very difficult for us to take them through the generic way of training providers on lack. So we needed to come up with an innovative strategy to training providers within the private sector. So we adopted the blended approach. Eugenia, next slide, please. So together with Jhpiego, we adopted the blended learning approach where providers can log on with the support from NMC, can log on with their pins, and then they have access to the course. This is supposed to take like 2 weeks. It is a self-paced, and then there are video tutorials. Let me just mention that the content for the training was adapted from Ghana Health Service that were converted into video tutorials. So you see myself and then other resource persons taking them through the course just to make it so interactive. And providers are supposed to come up with a score of 70 or more, so they qualify for the next phase, which is the in-person, and they have access to arm models, pelvic models. They are able, next slide please, they are able to practice more. We also introduce person-centered care, counseling for choice.
I'm not getting this slide.
Counseling for choice, which is a more person-centered approach to FP counseling. We can all attest to the fact that when it comes to family planning, it's not just mentioning the method, but then tailoring your counseling such that the response to the reproductive health needs of the clients is very critical. So aside the technical bit of the LAC training, we also introduce quality of care models. Next slide, please. So the third phase of the blended approach is the mentee and the mentor approach, where you have the facilities that have been recruited and being clustered into various zones, and then you have a mentor going in to support them. From the photo, you can see a mentor assisting a trainee to carry out an IUD insection. This is supposed to last for 6 weeks, but then some are able to finish before the 6 weeks. Let me also mention that this approach actually was very responsive and to the needs of the private sector, because the mentor has the opportunity to give direct feedback, and these mentors are also regional based. So we envision that there will be a form of working relationship beyond this project. Next slide, please. So what have we actually achieved? Eugenia has already mentioned we've been able to build a capacity of 100 private health facilities across 10 regions. We have been able to train 157 private health providers with cadres ranging from physician, midwives, community health nurses. We have been able to build their capacity. Data is very key, or is quite challenging when it comes to the private sector. So we have built their capacity so they can report directly into the DIMS. It is also worth mentioning that under the MCGL project led by Jhpiego, we have the online content being used. Also, the course, the blended approach, the online bit of it is also open. NMC also makes it available for nurses and midwives to have some CPD points for their PIN renewal. What have we learned from this blended approach? We have seen that it is more flexible, it is more responsive to the need of the private health provider, meaning that we don't have to pull them to a hotel for 2 weeks to carry out a residential training. This is more responsive to their need. And the mentee and mentor approach, we took a bit longer. Lessons learned took a bit longer. We had to make more effort, get our CBOs or our sub-grantees on board to generate demand so that they can have people to actually provide service for, so we can sign them off as competent. Thank you, and over.
Thank you so much, and congratulations for that rapid run through that really built out this comprehensive view. And I'm going to turn it over to Judy to bring in a few questions and answers. But I, first of all, just want to say thank you to everyone, and what a great flow of discussion, because I think it was so appropriate thinking about the predominance of short-term methods in the private sector, and also challenges around quality and with private providers. And then finishing by hearing about this activity to expand access to LARCs, and to do that in a training format, and kudos, that reflects the fact that it's difficult for providers to leave their offices for extended periods of time to take training. So just really fantastic. And Judy, over to you.
I think it has been wonderful to see the interactions in the comment section. So there's been a really lively discussion amongst presenters and participants. I think I would kick off with a question that hasn't been answered for DKT's Kwesi. It would be interesting to learn about the cost recovery model, especially with subsidized prices. Does the volume that DKT is able to realize compensate for value, or is it about cross-subsidy with other products such as the HIV products? And if when we're looking at subsidy, how much is the product portfolio currently reliant on subsidy? So over to you, Kwesi.
Thank you, Judy. I actually answered Leila's question, but it's yeah, it's the, what do you call it? I was mentioning that we have products, some products which are not family planning related, but they are related to sexual excitement, and so those ones are able to generate some margins, which margins go into support products like the IUD, like the HIV self-test kit, even like the OCP. These are all subsidized. So basically there's cross subsidization. You sell a lot of a particular item, you have some margins which can then cater for some of the things. In the past, when we had some donors, we had donors who were also interested in certain products. And so they would fund that. And so whether it was making losses or not, there was some amount of funding towards those products. But for now, it's more like sell a bit of things that you could make margins on to cater for the ones that have to be subsidized. Yeah.
Thank you so much for that response. I can see a comment from Pierre, and I wonder if it would be a good opportunity for him to talk a little bit more around the counseling for choice approach, and as he's highlighted how that has been integrated into the work that has been highlighted by both Eugenie and Salamatu. Pierre, would you welcome your contribution to that sense? Thanks.
Thanks, Judy. I mean, I've been put on the spot slightly. I've put a link in there to more information about this. It was actually a product developed under what used to be called the LARC and PM Community of Practice about 6 or 7 years ago, and many organisations on this call, Jhpiego, FHI 360, and too many to mention, all came together to look at whether we could review approaches to counselling. I think the question we were trying to answer was whether the approaches we had were fit for purposes, particularly for young people and adolescents. So, and it seems to have added a nice counselling approach to the mix. I don't think any one counselling approach is better than the others. There are some that are more suited to different providers and different audiences, but it certainly seems to have been very well received in Ghana. And so that was absolutely lovely to hear today. And on the subject of person-centred care, there'll actually be a number of tools and briefings coming on out on that as well, so that we have something more systematic that we can use to advance person-centred care, because there's some systematic things out there, but there's also a lot of theory still. So watch this space. We'll raise those resources when they become available in 2024. But thank you, Salamatu and Eugenia, for highlighting C4C. You've made our day here today. Thank you.
Thank you so much for that comment. Yeah. I think I wanted to also highlight that a number of discussions around delivering training, and the model around building primary care services for around pharmacy services that will be really complementary for to layer on family planning services, especially. And I wondered if I could give Dr. Hafiz a minute for him to just comment on some of the feedback that he is receiving from participants in this particular conversation.
Oh, thank you. I think I've tried my best to respond to everyone. I'm not sure. Is there anyone I have not yet responded to?
No, I think you have. I think you have responded really well, Dr. Hafiz. I think it was just. I thought I'd reach out and see, any final comments around what you're seeing is the opportunity around delivering family planning services based on the questions that we have received from the participants today.
Oh, yeah. Thank you. So my my comments would be that I have left it open so that organizations that are interested in partnering can reach out, because we're very much into collaboration at mPharma. To build something robust, we cannot do that alone in-house. I know we have some partnerships running in Nigeria that has developed family planning as in-pharmacy health service. Would be glad to see the same in Ghana, where patients can walk in, get implants, and so forth. But those sort of training, we don't have the in-house capacity to provide it to our pharmacists. So partnering with SFH or FHM will be good to make sure that we have a robust capacity to handle family planning going forward. And also for people like DKT who have sexual health products and are interested in listing it on our Multi-Plus service, so that with a prepayment, patients can just get access to the contraceptives they need, and they don't have to pay out of pocket every time. So those are collaborations we're looking forward to in the future. I'm excited about it. So thank you.
Thank you so much for that response. And we have come to the end of our session today. And I thought I'd just say a really huge thanks to our list of speakers today. It's been a real opportunity hosting the community of practice, working with USAID and UNFPA. The FHM Engage is the secretariat. We've had, I think, real conversations around the different models we are seeing here, both from those evolving their previous models. We've seen quite a bit of work, for example, today around MSI, looking at different models for engaging private sector that we feel is quite aligned to the approach that we are taking, but also seeing how the other partners really fit into expanding method choice within private sector, but also adopting these innovative channels to reach a greater audience and really expand how the services are delivered. So just a huge thanks to all the speakers today. Thank you for the effort that you have put into preparing your presentations and responding to the questions in the chat, responding to the questions of the participants. We will have our next Healthy Markets Community of Practice in January. We have a country-focused approach. In January of 2024, we will have speakers from Kenya present from the private sector, and we hope you'll be able to join us during that session. And I will ask Andrea to make a few last wishes. Happy holidays. Go ahead, Andrea.
Thank you, Judy. Sorry to be too enthusiastic. What I want to say also that we are going to be sending out, and I'm sorry to say it in a way, some type of very quick survey, which we had hoped we might have ready for today. But obviously, we're reflecting on the format that we've been using, and you can see we're trying to use short presentations, generate dialogue, do this in 90 minutes. So we're going to be asking for input about, do we modify? Would you consider 120 minutes? Like, what might be the right approach there? We also want to ask input on countries, because you'll notice, as Judy mentioned, that in January, we're going to, I'm going to say country host Kenya again. And it's much as we did in some other settings where we realized we can't fully cover things in just one session, and especially to have, say, 8 speakers. So that's one thing, is how to approach that. We also have a starting list of country ideas for at least the first quarter of 2024. But I want to say from a USAID viewpoint and UNFPA that while we're working closely with FHM Engage as the secretariat, we're also going to be thinking really carefully about other significant implementing partner projects and areas that may tap into countries that haven't been covered yet, and maybe some other large funded projects are a good entry point into countries where we all need to get to know the private sector and market development activities better. So we're also going to invite suggestions and potentially co-leaders or organizers along that line. So a lot to come. And again, thanks to everyone, and really appreciate this dialogue. And we never have enough time. So how to best wrestle with that. And the final point, and this is really on behalf of Ben Light as well as myself and Judy, is what about impact? When we get a really important conversation started, but we haven't fully captured a way to continue something, like if there's a certain connection made, and we still want to raise that idea for whether small groups want to come together as a result of something that might come up as an idea in one of these sessions. So we are going to be thinking hard about how to increase the impact and the follow-on, and we really invite your suggestions and offers to help leverage that opportunity. So thanks again to everyone, and best wishes for the holiday season and wellness to everyone. So thank you. And we'll see you in January. And in the meantime, you'll hear from us. So thank you.